today and can't be here, but we gather here today to get some information from at least two gentlemen who have some experience and some quite extensive experience in research during surgical residency. Our primary speaker, Dr. Bhattacharya, he went to a laundry list of places that include an undergraduate work and graduating with honors at Washington University, University of Tennessee for medical school, Duke University for not quite a decade with Dave, but it looks like from his CV at least 7 years. And then Vanderbilt for pediatric surgery. His research efforts include 2 research fellowships, one at WashU and one at Duke. He's licensed in Tennessee, Georgia, and North Carolina. He knows something about writing meaningful papers because he got the Southeastern Surgical Gold Medal Paper Award. And in another year, the Association for Academic Surgery Best Paper Award. Dr. Zug will follow with some comments, and I think we all know his contemporary, as your contemporary, his accomplishments. Maybe you just weren't quite clear on the pedigree for Dr. Bhattacharya, so we'll turn it over to him.
All right, so thanks everybody for coming today. My goal here is to make research easy, or at least somewhat more clear for all of you. I think it's really admirable that you have decided to come to a residency program where you commit a specific year to research, for those of you who don't do the critical care fellowship, and being able to get the most out of your time and not feel frustrated by having projects that don't see their way to a paper, I think it would be the most helpful use of our time here. So we're going to go over a few topics. What is research? Why do it? How do you find a question? How do I answer the research question? And then pitfalls and opportunities that we have here. So research comes in a host of different ways. Right now there are people in this room that are working on case reports. Dr. Capote and Zug are working on an interesting omphalocele baby that Dr. Kuntz worked on. Case series, a series of Dr. Sprouse's is being written up by Mary Catherine. Quality assessment, so currently benchmarking what we do here at this institution, and then quality improvement. So there's a current project working on how we communicate with the SICU patients and can we improve that communication. Retrospective cohort studies, Dr. Gates is finishing up a 1,000 patient review of how we do appendectomies in the pediatric side, which until currently there's only been small case series, but Dr. Kelly Smith and Kuntz have been doing it in a unique way, but unfortunately they've not written about it yet. So this will be a seminal paper for pediatric surgery on how do you do an appendectomy. And appendectomy sounds like such a straightforward thing. Can we really learn any more about it? Well, I think Dr. Gates' paper is going to show us that we certainly can. And then, as you know, Dr. Soder's worked extensively on his bowel anastomosis paper, so there's lots of educational research opportunities available. So the end of the topic is that you don't have to kill a mouse to get a paper. There's a lot of different things that we have right here in order to get something done. But why? Why bother doing research? I think the most important reason to do it is by understanding research, you can be a better consumer of research. So if you know what it takes to put together a paper, what is good, sound, valid research, you can look at somebody else's paper that you might find in a journal that you're hoping to apply to your specific clinical scenario and understand, is this something that applies to me? Is there a nuance to this that's not applicable to what I'm trying to use it for? And that's something I do, if not every day, at least several times a week. So being a good consumer of research is only bolstered by doing research yourself. I think in this new era where no longer are we talking about triple threats where you have to be a scientist, a teacher, an administrator, being a hospital citizen requires you to be good at quality assessment and quality improvement. And I say it's a critical skill for the physician because it's not just surgeons. You have to be able to relate your information to internal medicine doctors, cardiologists, nephrologists, pediatricians, what have you. And I assure you that just saying that you're really good at what you do is not good enough for other people. You need to have numbers. Surgeons are unique in that we do very specific things to very specific groups of people, and we can study it and we can actually talk meaningfully about how our patients do. And from what my interactions with other groups are, is they can't necessarily tell you that somebody with a rising creatinine may or may not get acute renal failure from a CT scan bolus of dye. And if they can't quote their numbers, then they automatically stand on a softer foot, whereas we can talk to a patient about colectomy with a dirty wound and their wound infection rate. So I think we have to recognize that we have a very specific opportunity and continue to protect that opportunity. You can't improve a system if you don't know what the benchmark score is, and it's up to us to create that benchmark score, or else they're going to create that benchmark score for us. Researching a topic gives you personally a better understanding of the subject matter, and specifically for those of you that are interested in doing a fellowship, don't think of it as a way to bolster your CV, but think of it as a way to really understand, if you're thinking about doing vascular surgery, understand all the different ways to do an extremity bypass. What are the endovascular techniques that you can use? What are the different conduits? Is this really something you want to commit the next 35 years of your life thinking about? If you do 5 or 6 projects and you still think it's interesting, then that'd probably be a good fit for you. If you find it incredibly dry and incredibly boring, then maybe you should move on to something else. So I think this is kind of a great way to get to know faculty, great way to know subject matter, great way to learn subspecialty problems and quandaries, and think about how you see yourself fitting into that network. Also allows you opportunities to go to meetings in that specific subspecialty, and those are all great ways to network for your future career. And then, we all have our own intrinsic biases. My appies never get a post-op bowel obstruction. All my kids go home in one day. Well, that's not necessarily true all the time. And by studying what you do, you can remove these biases and give factual data to the practices that you do every day. And I think also it's really important to be able to give better informed consent. So before the operation, if you can help guide a family through what the standard postoperative course and what the bumps in the road may be, I think they feel a lot better when you do meet those bumps, because if you operate enough, you will have those bumps. So how do you find a research question? Every day you round on 20, 30, 40 patients and you're met with clinical scenarios. You understand that all of your faculty have specific preferences and there are certain dogmas within this hospital and within all hospitals. So those are great opportunities to question and figure out, is this really true, or what we've done to Mr. Johnson, is that really the best way to approach his care? Read medical and surgical journals. So don't just read the blue journal that comes from the American College of Surgeons. Pick up one other journal every month, whether it's JAMA. I read New England Journal. I don't understand 2/3 of it. It's about these nuanced chemotherapeutics. But by understanding what your peers in the hospital are reading about and studying every day allows, again, you to be a better citizen of our hospital and better appreciate what role a surgeon may have in those arenas. When you go to a meeting, suffer through and listen to all the talks. There are other people that are working on similar topics that might be interesting to you. There's always this great hall of 100 posters with an eager resident standing out front to describe it to you, and maybe you can do something similarly. Maybe you can collaborate with them. And then Grandrounds presentations, when we have visiting speakers, maybe they have a specific interest that you might be able to foster here at our institution. So you have an idea. Now what do you do with it? So obviously go to PubMed, see if it's been written about, Google the topic, see what are the hot nuances of the topic. Is it mimic what you've done? Talk to people who may be familiar with the subject matter. So talk to your colorectal attending if it's a colorectal project. Talk to people within our department and people outside of our department. Sometimes GI doctors have a lot of really interesting nuances to what they do, and we don't appreciate that. And sometimes they have great questions that they can't answer because they don't have access to the patients. So you can facilitate projects here by being a liaison between 2 different departments, and that's, if you're good at working with teams and good at working across department lines, you can be very helpful and very productive. And then don't be afraid to talk to people at other institutions. If you went to medical school elsewhere, or if you know a co-resident that matched at some other institution and you guys have similar interests, there's lots of opportunities to work with people, and we have licensing contracts and cross-institutional IRBs that we can apply for that will make it very easy. So most importantly, understand if the project that you think you've come up with has been previously studied. Okay, so then you realize that 15 other people have already done this project. So go through those papers, print 5 of those papers and see, has it been done well? Just because somebody's done it, like Dr. Gates' project for single incision laparoscopic appendectomy, they only had 86 patients and they really had a very short follow-up, and they didn't talk about risk factors or how the kids did or who did well or who did poorly. So just because it's been done doesn't mean it's been done well. And can you replicate that study with a more valid model or with a more robust data set? Or is there a nuance to the question that's not been covered by the current literature? So they call it research because everybody searches and then you search again. It's perfectly okay to replicate a research project as long as you can come up with either a more robust response or a nuance to the question that's not been yet identified. So you had an idea, now you have a good idea. So now what do you do? So I think all research is much more helpful when you are driven by a hypothesis. So when we do X to these patients, they respond this way. So come up with a hypothesis that you want to test. Once you come up with a hypothesis, talk to Miss Pat, Dr. Stanley, myself, Dr. Carr, if you want to kind of help formulate something before you go further with it. Any of us have a lot of time. We meet every Wednesday at 10 a.m. in the small library. Even if you're not on research, you can come by at that time, or we're happy to meet outside of those hours to talk to you about your project. Then I think it's always helpful to have a faculty member within the specific division that you want to work in also support you, because certainly they understand the subject matter much better than Dr. Carr, Dr. Stanley, or myself might. So you have this good idea. Where people get hung up is there's all these barriers, and as residents and as medical students, you might have barriers that we can help you overcome. So first, understand those barriers to completing your project. Maybe it's $1 million project, and we certainly don't have the funds to support that. Maybe it'll take 100,000 patients to be able to answer this question. So before you go diving into a project, really understand what the barriers to completion are. And then I asked Dr. Holcomb to come, and she's here, and maybe she might speak at the end. She's our statistician from UTC who devotes 10% of her time, but really way more than that, to our department to help us with statistical analysis. So engaging her before you start building your database and before you start looking through patients will be very helpful. It will save you heartache in the back. Pick a realistic journal and a meeting deadline and create a timeline for creating your project. So if you just start a project with no end date in sight, the chances that you will finish it in a timely fashion are very small. So, you know, maybe it's this summer and the deadline for Southeastern Surgical is next summer. 12 months is a great timeline. It's a very realistic meeting. It's a very realistic journal to be able to submit your work to. So pick a deadline and then hold yourself and those that you're working with to those deadlines, because as I put in parentheses down the bottom, tomorrow is where research projects go to die. If you hold everything off till tomorrow, it will never happen. Tomorrow will come and go, and you will have no project at the end of the time. So the IRB, which everybody sweats over. So writing a well thought out IRB or SRC proposal will save you a lot of time in the back end. It's essentially the primer for your manuscript, and if you can describe your project on paper and how you're going to go about doing it, it will allow the SRC to give you unbiased feedback. They don't know what you're talking about, and if they can read it on 3 pages of paper and understand what you're talking about, you probably have something that will ultimately be a fruitful topic. They are much better probably at you or even I to understand the feasibility and our institutional capability of completing the project here. So again, if we need 100,000 patients and you write that in your SRC, well, they can maybe pump the brakes and say, this may not be able to be done here. Maybe we need to get access to a bigger database or what have you. But what I don't want you guys to do is spend hundreds of hours on a research project just to find out that it's not going to be able to be completed. I think that's very deflating, and as somebody who's done that before, I don't wish that on anybody. And then the hardest part is actually doing the research. So you've talked to everybody, you've written your IRB, you've got this huge spreadsheet that's completely blank. Now you got to fill in the spreadsheet, because if you don't fill in the spreadsheet, you have nothing to write about. So don't forget that part. Get help if you need it. So If you're hitting barriers, let somebody know. We can probably help you overcome them, or at least help you find your way through. And then you have this whole quarter of the room over here to help you get projects done. So this is a fantastic way to get medical students involved in our project, in fantastic way for interns and junior residents to get engaged in what research projects look like. So as a medical student, I spent a lot of time looking up hundreds of creatinines for this CT surgery project, and I would sit there, but then you got to go to the meeting and talk to the faculty member and understand why they were doing the project and get a really good nuance for what research is, and is that something that you might be interested in. Even if you're doing something completely non-surgically related, it can still be helpful to engage yourself in a good research project. And then for the senior residents, they're very helpful, and they will save you a lot of hours at 1 o'clock in the morning when you've got a deadline that you're holding yourself to. Having other people's names on the project is not a sign of weakness. It's a sign of collaborative and how do you manage a team. So using all the resources available to you, again, make sure you stay on your timeline. So now that you've gathered all your spreadsheets and you've gotten all the data you think you need, go through your statistical analysis, whether it's Dr. Holcomb or you have another stats person helping you. Get your analyses and then do a careful review of the data. So when I was doing research projects, especially when there were years-long projects, I would go through the data about every month or every 6 weeks and make sure that the guys that were helping me with the project were putting the data in the spreadsheet properly, make sure they understood, kind of go through and back check one or two of theirs to make sure they were capturing all the things they were supposed to capture. And then sometimes about 2/3 of the way through the project, you'll recognize that, well, maybe what I'm looking for is not real, but there's some other nuance to the data that we can find out from this. Just because you have a negative study, let's say the stats come back and nothing's significant, well, that can still be a meaningful paper. I think just because you do an intervention and there's no difference in the two patient populations doesn't mean that you don't write about it. I think saying that there's no difference is still helpful to keep somebody else from thinking there's something unique about that technique or intervention. So you can almost always learn something from every data set. And then sometimes, even if you have a negative study, you'll realize, well, shoot, I forgot that we didn't look at these CT scans or we didn't look at this ultrasound. And maybe by just gathering one or two more data sets from each patient, you can come up with either a different hypothesis or better clarify your data. So now that you've done all that, this goes on to writing the abstract. So understand your target audience. So are you submitting this to the American College of Surgeons or the Tennessee chapter of the American College of Surgeons, where it's really a general surgery group? Are you submitting it to the Association of Pediatric Surgery or SVS? Is this a subspecialty group? Because the way that you write your abstract is going to be predicated upon who your audience is. Maybe it's a non-surgical group. Maybe you want to write a bowel anastomosis paper for resident education to a GME meeting. They have no idea what a bowel anastomosis is. They have no idea what it takes to teach somebody how to do a bowel anastomosis. So really writing your abstract in a way that will be meaningful to them and have them appreciate what you've done is very important. One thing that I think a lot of people forget about is that almost all journals and almost all meetings allow you to submit a table or a chart or some graphic. And people often don't want to read your 4 or 5 paragraph abstract, but if you have a compelling bar graph with confidence intervals or odds ratios, if it's compelling enough, they will go back and read your abstract, and that will greatly increase your chances of getting it on to the meeting. And as soon as you finish writing your abstract, immediately start writing your manuscript. You have this SRC, you have the abstract, you're completely fresh with the data. Nobody knows the data better than you do. Dr. Holcomb, your statistician, has just finished the data mining and done the statistical analysis. That is your best time to make charts, to write the manuscript. You're never going to be more familiar with the data than you are as soon as you submit that abstract. So that being said, that's kind of how I envision that all of us here can go through a research project from beginning to end. And I don't know if anybody else has any questions or any other input, but I don't know. Dr. Zug, do you want to chime in on your experiences?
So that was a eloquent presentation, Dr. Bhattacharya has been a huge help to me. It's incredible how much he was able to accomplish at Duke, and we have everything that we need here to be just as accomplished with research here. So I just want to take a few minutes to talk about my experience and how to make room for research during residency. And a lot of this is geared towards the interns. I want to be able to show you all that you guys can do research and get a lot done in 6 years in residency. I was incredibly intimidated with just being in residency and being a doctor as an intern. And I was just trying to figure out how to tie my shoes and really did not want to think about anything else but how to figure out what I was doing. But I also realized that I had some long-term goals, and I had some pretty lofty long-term goals, so I had to make a plan. And I stuck to that plan, and I think I've been able to do a lot. A lot of things Dr. Bhattacharya said in his talk, I hope that you guys were listening and understood what he was saying. He said a lot of things that are going to make or break a project for you, and how easy it is to do things and how difficult it can be if you don't do all the little things that you need to do. But I've been given a lot of opportunities to do research. So far, there's a lot of people that made that a lot easier for me. Pat Lewis, I don't know if she's here, but she's been incredible. She's awesome and made everything so much easier for me. If you're an intern and you have a question about how to do something, go to her first. I hope she's not mad at me for saying that, but she's awesome. Also, Dr. Nelson, Dr. Stanley, Maxwell, Bhattacharya, Brzezinski, and a lot of others have been very helpful to me. I've been able to, I most likely will have 7 peer-reviewed publications. I've had 5 that have been accepted so far and 2 that I'm writing the manuscripts. Also been able to publish 3 case reports so far, working on 2 more, so hopefully 5. And case reports are great. They're really easy to do once you figure out how to do it. It's 2 lines on your CV. It's a publication. It's a presentation, usually at a meeting in a cool place, and they're something that are pretty easy to do and get done. I've been able to present in Chattanooga and Nashville, Atlanta, New York City, Chicago, Seattle. I got a scholarship to go to the ACS Leadership and Advocacy Summit with Dr. Giles, and I think the reason I got that was directly because of my application letter where I wrote about the research that I'd done and the leadership skills I developed, specifically with the ERAS project. That was when the big project that I got started and gave me a lot of experience. I've won a couple awards. This plastic surgery project that I did, that I helped with, won first place at the Southeastern meeting and is being presented at basically the ACS of plastic surgery this year as a podium presentation. So that's going to be huge. And then the C. diff project won third place at the Resident Research Day. That was a project that was pretty much already finished, and I took it over and finished it and wrote the manuscript with Dr. Stanley, and that's turned into another project. So I've got 2 manuscripts off of a project that a resident couldn't even finish when they were in residency. So there's lots of opportunities to do things, not even starting from the beginning. I was also invited to review articles in a journal, and I'm hoping that all these things will help me stand out when I go to interview for a fellowship. So what's the point? When I started residency, as I said, I did not even want to do research. I had no clue why anyone would want to do research. I was not interested in it at all, and that's totally changed. I started doing it because I wanted to be competitive for a fellowship, and it's turned into something that I really have enjoyed and like to do. And I think most importantly, it makes you a better doctor. Learning about how to read critically and look at evidence-based medicine, that makes you a better doctor. It helps you take better care of your patients. In any research project, the literature review is usually one of my favorite parts, because after I'm done doing the literature review, I feel like I know a lot and I'm an expert on on that topic, and I can talk to patients better about patients who are having elective colon surgery, patients who have C. diff, patients with diverticulitis. Those are all things I feel really comfortable talking to patients about, and comfortable in managing them and taking care of them. It provides skills for lifelong learning and leading. This is something else I did not know would happen, but we're leaders in our hospitals, in the operating room, in the office, in our communities, with our families, and learning how to be an effective leader is difficult to do. But people look to us. They look to us for help with lots of things outside of taking care of patients. And I think it's important. Research has been important in developing those leadership skills for me. Also, I've been able to develop some close relationships with some of my attendings. These attendings are the people who are going to write my letters of recommendations for a fellowship. They're going to be the people who recommend you to other surgeons in the community when you go to get your first job. The attendings that I've worked with on research are the people that I'm closest with, and going to and talking, asking them questions about taking care of patients, the projects we're working on, and just in general, if I'm stressed out about something, those are the people I go talk to. And then I've mentioned this, but research makes you competitive for that next job or a fellowship. I knew I had to get started early. And I made that plan, that long-term plan, and I've been able to stick to it. We've got so much time in the hospital, and I did not really realize that until, 3/4 of the way through intern year. There's time waiting after rounds to run the list. There's time between cases. There's time waiting on attendings. There's so much time that we're here. We're here for 6 years. Most of that time we're taking care of patients, but a lot of the time we're not taking care of patients and we're just sitting around. And there's so much time we're here that you can be productive doing something. Once I figured that out, I was able to get a lot done. And even if you don't do the research year, there's a lot of time. Chris Bell has killed it. I mean, he's done a lot of projects, and he did the fellowship. So he's a good example of how much time we have and what we can get done. So what have I learned? Interns get started now. Research teaches you a lot in how to be a better doctor, how to look at evidence more critically, make conclusions. Teaches you how to plan ahead, be a leader, develop relationships. These are all skills you need for a successful career. These are all habits that you need to create early, so throughout your residency you can get better at them, and when you're done with residency you can hopefully have a successful practice and career. I went from not even knowing how to do anything with research to having attendings come to me and ask me for pointers and help with a project. That's just shows how much that I've come along. I've had but I think the next thing that I figured out was I decided what I wanted to do with my life early. So you need to figure out if you want to go into private practice or an academic type of career. You need to figure out what kind of surgery you want to do. You need to figure out if you want to live in a small town, if you want to live in a big city. All these things are important in helping you understand how competitive you need to be for that next step. I wanted to do a competitive fellowship. I want to live in a big city that's already saturated with a bunch of specialists. So I knew I needed to stand out. I also knew that I wasn't going to be a 99th percentile guy on my tests, but the research and developing those relationships with attendings would help me stand out. Let's see. So the next thing, finding an appropriate research mentor. It's very difficult to figure out how to get a good research question, create a feasible study design, and then finding the right research mentor can help you do those things. Sometimes they can they can not know your timeline and your goals and can hurt you at times, but most of the time they're helpful. The next thing, learn how to do it right the first time. It'll save you headaches later. Specifically with the ERAS project, it was very exciting for this hospital for me to do and watch patients do better. But it was already being done all around the country and in Europe. And by the time I had enough patients to write a paper, it wasn't novel anymore. And it's been difficult. We had to kind of get a little bit creative with writing the manuscript and what we've done differently here and how we can add to the literature. But it's still being difficult. We kind of missed the boat. I think it'll get published, but haven't gotten it published yet. And that's, I put more time into that. Y'all know I put more time into that than anything else. So it was good to go to New York and present that. That was a lot of fun. And then lastly, I think find projects you can finish in an appropriate amount of time. This is where your research mentor can help you. And obviously, this is hard to do because I've taken over 2 projects for residents who haven't finished them in their residency, and I've gotten 3 publications, and I've gone to several meetings because, they weren't able to finish it. And I really didn't have to do a whole lot of work. I had to put in some work, but not, a project from start to finish. So that's kind of my experience. I'm always available if y'all need help with anything. And success is where preparation and opportunity meet. Believe in your hustle, not just luck. Any questions?
Dr. Holcomb, time for her day to come just so she can participate. If you want to come to my friend, you can. But just things that you think would be helpful for these guys to understand as they're creating projects.
I actually just made a couple of notes as these guys were talking about things that I wanted to mention. First of all, as you are starting a project and you get that idea and you're working on that SRC proposal or your IRB, they're oftentimes going to want a power analysis from you, and I can definitely help out with that piece. And that also gives me an opportunity to talk with you about your project, about the variables that you're interested in, maybe how those variables exist if you're looking at a pre-existing data set, or how they may be collected if you're going to collect that data on your own. And it'll give us an opportunity to decide what those variables are going to look like in the data set on the front end and how they should be coded. And that makes everything run smoother as you go through your data collection phase, and then whether you work with me or another statistician on your actual analysis, it will help that piece of the process run smoother and quicker for you. So that's the data gathering piece. Just setting up the spreadsheet and knowing how things should look are going to really streamline that process. And then also with the manuscript writing piece, I can assist with that results section and what things should look like, how things should be worded, which is oftentimes a place where your expertise is not going to be. You guys are content experts, and that's what I enjoy about working with the residents here, is that I'm not a content expert at all in anything that you do, but I'm a content expert when it comes to methodology and statistics, and so it's a nice marriage of skill sets when it comes to the point of writing that manuscript where we can help each other and put something together that's meaningful. The final thing that I thought of just at the very end was kind of a non-data related thing, is to kind of keep a journal, keep thoughts and keep notes about the research that you're doing and the thoughts that you have about particular projects as you're working through them, not only to gain ideas. So if there's cases you're working on, or patients you're interacting with, or presentations that you're watching, to keep notes about potential ideas, because you may be able to build on those later. And that's what I do. Any of you guys who have worked with me in the past know that I always have my notebook with me. And when I go to a conference, I often come back with a laundry list of potential ideas for research projects in the future. And so that's a great place where you can get ideas, but also that you can look back and think, where did that idea come from, and why was it that I was collecting this data to begin with? And it might help you with that manuscript and your final discussion of your topic as you're writing things up.
While we get the microphones, did you want to speak, Dan?
I might just say a
Okay.
few things, if that's okay.
Absolutely.
First of all, I just really appreciate all the hard work that the residents put into the research. I think the last 5 to 10 years, I've seen just a lot of real diligent work. It just seems like, I remember 15 years ago, it seems like we'd find people out on the golf course, and maybe people make it out there occasionally, but I think you all have done a great job, and especially having Dr. Carr and Dr. Bhattacharya really helping out has been great. I wanted to reiterate a couple things. I think some of the main points, if you could take home with, is kind of the idea of working smart rather than working hard. I mean, you want you to work hard, but I think the people that have been really successful, I think of Ann Royer, I think of Dr. Zug and Bell. They did the things you mentioned. They started early, and they also communicated well. I think Anna was a good example of somebody who started out poorly because of a poor choice of a project, and she really suffered through trying to work through them. But I think what came out of that is that the harder you work on the front end as far as getting a good question, one that's very feasible, somebody you can work with, if you do those three things, the other parts will be easy and you'll find it's fun. If you don't do that part, and somebody maybe corners you and say, hey, I've got this data set, I want you to see what you find, and you just start doing that, you're going to have a lot of trouble. So I think you interns, go ahead and start reading journals, go into the meetings, and when you go to the meetings, think about what you might be interested in your area, like Dr. Zug did, and then come up with a research question and come to the meeting early, meet with me, meet with Dr. Bhattacharya, Dr. Carr, or even Dr. Zug, some of the others that you see as good mentors, and get a question early, and then we can get you reading the text that we have to help you design the study, and you'll get going. So those are just a few of the things that I want you to think about. It can be fun, or it can be really a drag depending on how you set things up. So anyway, our doors are always open. Sometimes you do have to beat on us a little bit and say, hey, we need to meet and get a time. That's, I think, where we can hurt you as mentors. And I can help you find a good mentor. The other thing is we always want you to have a mentor within our department on any project you have. Oftentimes you're working with other departments, but we also want someone in our department working alongside you, so make sure you remember that.
All righty, thank you very much. I'll reflect a little bit before we open the floor up and get the microphones to whoever wants to do it. When you were talking about deadlines, I remember my graduate advisor telling me, more if you write a page a day, in 30 days you got 30 pages. Now, when it came to that, I might turn 30 pages into them, and there would be big red X's across the page. And then I would turn them in, and they'd continue to do that. And so my question, and then sometimes I swear, and when I got it back in the final iteration, it was what I gave them the first time. But how did you develop your writing style, and how long did it take you to actually get a writing style?
I will say that is probably my biggest shortcoming, or one of my many shortcomings, is writing. So I'm really good at horsing through data and looking through big spreadsheets, but writing is one of my weaknesses. So I have to find similar papers and kind of model the tenor of the paper from other manuscripts, and that's okay. I did science and math. I'm not a writer, so it takes a long time. It takes writing a lot of papers before you can even have something that's passable. That's not something that we're used to doing, so it is unnatural for us. So,
Dr. Zug, what did you find out about your writing style so far?
I don't know if I'm a good writer or not, but the way that I do it is, you know, I don't plagiarize, but I do my literature review. I get all those papers, I set them out, and I just start writing. And you know, you kind of get the language from reading the other papers. And
you found your mentors put X's on certain things and.
oh yeah, lots of X's.
Oh, okay.
But that's just kind of how I do it.
Yeah. So Dr. Zug is an above-average writer, I have to say. He does pretty well. There are some that are horrible writers, and there's some that are just fantastic. It's amazing to see the difference. I'm not a good writer, but let me just tell you the experience I had. I didn't do any research for the first 10 years of my practice. For some reason, Dr. Burns decided I was going to be the research director. And so I had to write a paper, and I wrote this paper, and I was very proud of the paper, and I showed it to Dr. Burns, and Dr. Burns kind of said, well, that's okay. And I said, okay, well, great. And he said, but let's sit down. And so he started marking the red marks. And then I went through and I wrote it again. I said, hey, this is good. You really helped me a lot. I said, I think your name should be on the paper. He said, no, I don't think I need to have my name on that paper. And I was like, why? We said, well, let's sit down again. So we went through it again, and then we went through it again. And this was when he had hurt his leg, and he had plenty of time. And my wife would be in the department. I'd be ready to go, and he said, I've got time now. I said, well, I've got to go. He said, I've got time now. And so what I learned from that is that if you really, and being a reviewer also has helped me understand this, is that writing the paper, first of all, you need to read some books about how to write. And then you need to write, and you need to go over it again and again and again, and then you need to have other people look at it and go again, because if it's very well written, the reviewer is going to want to try to get that paper on. If it's not well written, it's like automatic. It doesn't matter how good your information is. They're going to say, forget, this is too much work to get it publishable just as far as the reader goes, so you've got to write it well. But it does take a lot of work, and I really appreciate Dr. Burns' taking the time that he did to mentor. And so if you have anybody that will put red marks, appreciate that.
I'm curious about Dr. Lorenzo's, how you develop your writing style, because you're an incredible writer.
Well, I guess I haven't really thought about my writing style. I do similar things to you all, but I will say in all aspects of my life, not just writing, but surgery, I'm very methodical. And I think being methodical does two things for you. One, you have an outline, and once you have an outline, it's very easy to follow. You just plug your data into those spots. And then I think it's much easier to get from point A to point B if you know where point B is. So that's what you said, Dr. Zhu, where if you happen to know where you want to go early, it's much easier to get there. And then I think practice, practice, practice. The more you do it, the better you get.
Doctor, you have any comments on development of writing style?
Well, I have to kind of speak the same as Dr. Bhattacharya. I am a science math person, although math is definitely my forte, and so writing is a very difficult thing for me as well. I also agree with the methodical piece of it. I think that's why, for me, the methods and the results section come very easily, because I see those sections as very structured. Other people who I work with regularly, colleagues of mine who enjoy the writing piece and enjoy the literature review piece, also see those as methodical, but that's not the way my brain turns. So I think that for each of you, you may find different aspects of the writing to be more difficult than others, and that's where you have this time to recognize where your strengths and weaknesses are as a writer, and to find people to pair with that make that work. So.
Any other questions or comments from you? Well, all you people who are interested in moving forward, you can certainly look around the room. You can find the residents that have all been involved, and that's where I would start, and they'd get you into the right direction to Dr. Stanley, who can guide you to every other mentor that's here. And I think that we'll go ahead and conclude, and thank you very much.